Welcome to the Rare Wellness Podcast. The pressures of this modern life, society, and world often steer us toward unhealthy lifestyles. Wellness is a rare treasure, hidden in the maze of daily challenges. In this podcast, we illuminate uncommon pathways to health and vitality, exploring cutting-edge ideas in regenerative, longevity, and performance medicine. I'm your host, Dr. Jamie Lewis, and today we're tackling something that comes up in our clinic literally every day. Our patients have questions about GLP-1 medications, semaglutide, tirzepatide, and honestly, there is so much noise out there, so much fear, so much misinformation. Today, Becca and I are just going to sit down and answer the real questions we actually hear from real patients.
And these are great questions. These are the things people are Googling at midnight, the things they're asking in our waiting room, the things they're hearing from friends who may or may not have any idea what they're talking about.
Exactly. So let's clear the air. I'm joined by Becca Pabona, one of our performance medicine nurses here at the clinic. This podcast is brought to you by the Center for Regenerative and Performance Medicine, located in the beautiful Pacific Northwest. Visit us online at www.c4rpm.com.
Quick disclaimer, this podcast is for educational purposes only and is not intended as medical advice. Always consult a qualified healthcare professional for any medical concerns or treatment. All right, let's get into it.
All right, Becca, let's start with the big one. Before people even pick up the pen, the first question is always, what's this going to do to me? What are the side effects?
Every single time, and honestly, I love this question because it tells me the patient is taking this seriously. They're not just looking for a quick fix. They want to understand what they're putting in their body. So let's just be upfront about it.
The clinical trial data is extensive. A pooled analysis of the step 1 through 3 trials looked at over 2,100 patients on semaglutide 2.4 milligrams. The most common side effect was nausea. About 44% of patients experienced it. Diarrhea was around 30%, vomiting about 25%, and constipation around 24%.
Okay, but before anyone panics at those numbers, context is everything. Those are trial numbers. In the trials, they escalated doses on a fixed schedule, the same timeline for everyone, no matter how they felt. That's not how we do it.
That's such an important point. In our clinic, we use microdosing and patient-specific dose titration. What does that mean? It means we don't rush. If you're doing well at a lower dose, we stay there. If you're having some nausea, we slow down. We might even drop back and let your body catch up. We're not following a rigid protocol from a pharmaceutical trial. We're treating you.
And that makes a huge difference. When we microdose and titrate based on how each patient is actually responding, side effects are significantly reduced compared to what the trials reported. I'd say the majority of our patients experience mild nausea at most, and many have minimal side effects at all. It's a completely different experience than what you read online.
And even in the trials where they weren't doing individualized titration, 99.5% of GI side effects were classified as non-serious, and 98% were mild to moderate. Only about 4% of patients discontinued the medication because of GI issues. So, even in the worst case scenario, the overwhelming majority of patients get through it.
The other thing I always tell patients is most of these side effects happen during the dose escalation phase, those first few months. By around week 20, the rate of new GI complaints essentially levels off. Your body adjusts, and with our approach of going slow and listening to your body, most patients adjust even faster.
Practical stuff helps too. Eating smaller meals, avoiding greasy or heavy foods, staying well hydrated, eating slowly. These are simple things we coach every patient through. We also watch for less common things like gallbladder issues. Gallstones occurred in about 2.6% of patients on semaglutide in the Step 1 trial. Not common, but if someone starts having unusual abdominal pain, we're on it.
Bottom line, side effects are real, but they are manageable, usually temporary, and with the right clinical team doing individualized dosing, they can be dramatically minimized compared to what the published trial data shows. Okay, this one I hear constantly. Patients come in and say, I've seen what happens to people on Ozempic, the sunken face, the saggy skin. I don't want that.
And I get it. The media has had a field day with terms like Ozempic face and Ozempic body, and the photos can be alarming. So let's actually talk about what's going on there.
Because it's not what most people think.
Right, those hallmarks, hollowed cheeks, sunken temples, loose skin, more prominent wrinkles, are not a direct effect of the medication itself. They're a consequence of rapid, uncontrolled weight loss. A 2024 review in Dermatological Reviews specifically described this as being driven by loss of facial subcutaneous fat combined with decreased collagen and elastin. And here's the thing, this happens with any form of significant rapid weight loss, bariatric surgery, crash diets. It's not unique to GLP-1s at all.
So then the question is, why does it seem to happen more with these medications? And the answer is, it happens when the weight loss is unsupervised. When someone gets a prescription from an online clinic, loses weight fast, eats whatever they feel like, which isn't much, doesn't exercise, doesn't prioritize protein, doesn't do any strength training. Of course you're going to lose muscle along with the fat.
Now the clinical trial data does show lean mass loss. In the STEP 1 trial, about 40% of total weight loss on semaglutide was lean mass. A presentation at Endo 2025 from Harvard researchers confirmed that women and older adults are at the highest risk. So it is a real concern.
But, and this is the big but, that doesn't have to be your story.
Not even close. A 2025 peer-reviewed case series described patients who combined their GLP-1 medications with structured resistance training and adequate protein intake. One patient lost 33% of their body weight with only a 7% decrease in lean tissue. Another patient actually gained lean mass while losing over a quarter of their body weight. A third gained nearly 6% lean tissue while losing 13% total weight. Those are remarkable results.
And that's what we do here. We use in-body body composition scans to track exactly what's happening. Not just your total weight, but how much is fat, how much is muscle, where it's distributed. We're watching those numbers at every visit. If your lean mass starts dropping more than it should, we adjust. We modify the dose, we change the nutrition plan, we ramp up the strength program.
That's the difference between careful dose titration combined with a medically guided nutrition and strengthening program versus just getting a prescription and being told, good luck. With our approach, you can actually minimize muscle loss or even gain muscle while losing significant body fat. The studies that showed alarming lean mass loss did not include those interventions. When you add them, the outcome is completely different.
So when patients say, I don't want to look like those people, we say, you won't. Because we're not just prescribing a medication, we're managing your body composition, your nutrition, your training, and your dose all together. Okay, so this is a big one, and it comes in two flavors. Flavor 1, I'm still hungry, this isn't doing anything. And flavor 2, I still think about food all the time.
Two very different things, and I'm glad you made that distinction. Let's talk about both. First, on hunger. I want to be really clear about something. Your appetite is not supposed to go away.
Say that again for the people in the back.
Your appetite is not supposed to disappear. You are supposed to eat. You need to eat. Your body needs fuel. It needs protein. It needs nutrients. The goal of these medications is not to make you stop eating. The goal is to normalize your appetite so that it's proportional to what your body actually needs, not driven by broken metabolic signals.
That's such an important reframe because some patients think the medication isn't working unless they have zero desire to eat, and that's actually not healthy. If you have no appetite at all, we need to look at your dose. You might be on too much.
Now, a lot of patients also don't feel much appetite change early on, and that's because of the dose escalation. You start low and titrate up over weeks to months. At the starting dose, many patients feel minimal change. The full therapeutic effect on satiety generally develops as the dose increases. Be patient.
And then there's the other piece, food noise. Let's talk about that because it's one of the most life-changing things about these medications and nobody talks about it enough.
Food noise is a term that describes persistent, intrusive thoughts about food even when you're not physically hungry. It's that constant mental chatter. What's for dinner? I want something sweet. Should I eat? I shouldn't eat, but I want to eat. It's exhausting. And for many people, it's been running in the background their entire lives.
And they think it's normal. They think everyone thinks about food that much.
Exactly. And research published in PMC in 2023 defined food noise as heightened and persistent manifestations of food cue reactivity, leading to intrusive food-related thoughts. fMRI studies have shown that GLP-1 medications actually dampen activity in the brain's reward centers, the nucleus accumbens, the ventral tegmental area, regions involved in cravings and dopamine-driven reward seeking. So these medications aren't just making your stomach feel full, they're turning down the volume on the food chatter in your brain.
I have patients who literally cry when they describe this. They say, for the first time in my life, I'm not thinking about food all day. I didn't know it could be like this. That mental freedom is, for many people, more meaningful than the weight loss itself.
Now, cravings specifically, especially for sugar and processed foods, can persist if there are underlying drivers we haven't addressed. Insulin resistance, hormonal imbalances, poor sleep, chronic stress, these all fuel cravings through separate pathways. The GLP-1 helps, but it works best as part of a comprehensive approach that addresses those root causes too.
So if you still feel like it's not working, first, give it time. Second, make sure your dose has been properly titrated. And third, talk to your team about what else might be driving your cravings. The medication is a powerful tool, but it's not the only tool. This is the one where I see the most frustration. A patient comes in after 2 or 3 weeks and says, I only lost 1.5 pounds. I thought this was supposed to be a miracle drug.
And my heart goes out to them because the expectations set by social media and marketing are just wildly unrealistic. So let's set the record straight with actual data.
Please.
The Step 1 trial, published in the New England Journal of Medicine, showed an average weight loss of 14.9% of body weight over 68 weeks. That's about 16 months. For a 200-pound person, that's roughly 30 pounds over 16 months. Do the math. That's less than 0.5 pound per week on average.
Wait, less than 0.5 pound a week from the most successful weight loss medication trial in history?
That's the average. And weight loss is not linear. Some weeks you'll drop 2 or 3 pounds. Other weeks, the scale won't budge. Some weeks it goes up because of water, hormonal fluctuations, or because you're building lean tissue through your strength training. That's actually a good thing.
This is exactly why we don't rely on the scale alone. We use in-body body composition scans. We track waist circumference. We look at how your clothes fit. And most importantly, we track your lab values because you can be dramatically improving your insulin sensitivity, your A1C, your triglycerides, your inflammatory markers, all while the scale barely moves.
I tell patients all the time, the scale is the laziest metric in medicine. It can't tell you if you lost fat or muscle. It can't tell you if your metabolic health is improving. It's a single number that misses 90% of the story. If you're building muscle and losing fat at the same time, your scale weight might not change at all. And that would actually be an incredible result.
The other thing is consistency over months, not weeks. We're looking at trends over 3, 6, 12 months, not what happens between Tuesday and Friday. If you're trending in the right direction on your in-body scans and labs, you're winning, period.
So stop letting the scale discourage you. Trust the process, trust the data, and trust your clinical team.
All right, hair loss. This one really gets people worried, and I understand why. Especially for women, this can be really emotional.
It is emotional, and it's getting more attention because more people are on these medications now. So let's look at the science and then talk about what we actually do about it.
Because there are things we can do.
Absolutely. A 2025 systematic review in the International Journal of Dermatology looked across pharmacovigilance databases and cohort studies and found that semaglutide and tirzepatide do have a slightly elevated reporting association with hair loss. The largest real-world study looking at over 500,000 matched patients found the risk of non-scarring hair loss was about 1.4 times higher in GLP-1 users at 12 months. So there is a signal there.
But here's the critical nuance. The primary type of hair loss we're seeing is called telogen effluvium, and this is not caused by the medication directly. It's triggered by the metabolic stress of rapid weight loss and the nutritional deficiencies that come with significantly reduced food intake.
The mechanism makes sense. When you dramatically cut your caloric intake, levels of key micronutrients drop. Iron, zinc, B vitamins, vitamin D, biotin. These are critical for the hair growth cycle. When they become depleted, hair follicles shift prematurely from the growth phase into the resting phase. 3 to 6 months later, that hair starts to shed. It's a delayed reaction.
And the most important thing to know, telogen effluvium is almost always temporary and reversible. When nutritional levels are corrected and weight stabilizes, hair regrowth typically occurs.
So here's what we do proactively. We don't wait for someone to start losing hair. We get ahead of it. We monitor labs from the start, and we supplement strategically. Specifically, we optimize vitamin D. And I'm not talking about just getting above 30 nanograms per milliliter, which is the conventional normal threshold. We target 50 to 80 nanograms per milliliter because that's where the research shows optimal tissue function, including for hair follicle health.
We also use methylated B12 injections. This is a big one. Oral B12 supplements have variable absorption, especially in patients on GLP-1 medications where gastric emptying is altered. Methylated B12 injections bypass the GI tract entirely and deliver the active form of B12 directly into the body. Many patients notice improved energy and hair quality within weeks of starting injections.
We also check and optimize ferritin. Our target is above 50 nanograms per milliliter, ideally 80 to 100. We supplement zinc, biotin, and ensure patients are getting adequate omega-3 fatty acids and a quality multivitamin. And of course, protein. Your hair is literally made of protein. If you're not eating enough, your body will divert resources away from hair to keep vital organs running.
So the bottom line on hair loss, yes, it can happen, but it's usually temporary. It's driven by nutritional deficiency rather than the medication itself. And with proactive lab monitoring, targeted supplementation, including methylated B12 injections and vitamin D optimization, and adequate protein intake, it can be prevented or significantly minimized.
And if someone is experiencing hair shedding, don't panic. Come in, let us check your levels, let us get you on the right supplements. In most cases, this reverses completely.
Fatigue is a huge one. Patients say, I'm happy I'm losing weight, but I have zero energy, I'm dragging.
And they assume it's the medication, but the reality is more nuanced than that. Let's break down what's actually causing the fatigue, because once you understand it, you can fix it.
First and most obvious, you're eating a lot less. Research shows semaglutide can reduce overall daily energy intake by about 24%, and at individual meals, the reduction can be as high as 35 to 39%. That is a massive caloric deficit. Less fuel coming in means less energy available. Your body is going to feel that.
But the issue isn't just total calories, it's what you're eating. Many patients on GLP-1s are eating less across the board, but protein takes the biggest hit because it's harder to eat when your appetite is suppressed. And that's the one macronutrient you cannot afford to cut. Protein fuels stable blood sugar, supports neurotransmitter production, preserves muscle, and sustains energy. We target a minimum of 1.2 grams per kilogram per day, and ideally 1.6 or higher for patients in a strength training program.
Second, micronutrient depletion. When you dramatically reduce food intake, you reduce intake of B vitamins, iron, magnesium, vitamin D, all critical for energy production at the cellular level. B12 is especially important because GLP-1 medications can affect B12 absorption, similar to what we see with metformin.
This is another reason we use methylated B12 injections for our GLP-1 patients. It directly addresses one of the most common causes of fatigue in this population. Many patients notice a significant energy improvement within weeks of starting B12 injections. We also check and optimize vitamin D, iron studies, and magnesium.
Third, hormones. If someone has suboptimal hormone levels, low testosterone, cortisol imbalances, or other hormonal factors, the caloric deficit from the medication can amplify those symptoms. Someone who is barely managing before the GLP-1 can get tipped into real fatigue once the additional metabolic stress is added.
So here's the practical playbook for fighting fatigue on a GLP-1. 1. Eat enough. Even when you're not hungry, you still need to fuel your body. 3 structured meals a day with protein at every single one. 2. Prioritize protein above all else. It's the most important macronutrient for energy, muscle preservation, and satiety. 3. Stay hydrated. Appetite for fluids often drops along with appetite for food. Dehydration alone causes significant fatigue. 4. Get your labs checked regularly. B12, vitamin D, iron, magnesium, and hormones should be evaluated and optimized. 5. Move your body. It sounds counterintuitive, but moderate exercise actually improves energy. Even a 10-minute walk after meals makes a noticeable difference.
The medication should be making your life better, not making you exhausted. If you're dragging, something needs to be investigated and corrected. Don't just push through it.
This might be the most important question we address today, and I want to be honest and also nuanced about it, because the answer isn't as simple as the headlines make it seem.
Every patient asks this. Is this forever? Am I going to be on this for the rest of my life?
Here's what the trial data shows. The Step 1 extension study, published in 2022, followed patients for 1 year after they stopped semaglutide. During treatment, patients had lost an average of 17.3% of their body weight. After stopping 1 year later, they regained approximately 2/3 of that weight. A 2025 meta-analysis in eClinical Medicine confirmed this across 18 trials and over 3,700 patients.
2/3. That scares people, and I understand why.
It should get your attention. But here's the critical context that never makes it into the headlines. In those studies, the patients who regained weight had minimal modifications to their activity, nutrition, and lifestyle during treatment. The Step 1 extension specifically noted that lifestyle intervention was discontinued at the same time as the medication. So they stopped the drug and stopped the lifestyle support simultaneously. Of course they regained weight.
That's like saying we stopped the medication and also stopped everything else that was helping. Well, what did you expect?
Exactly. And there's real-world data that tells a different story. A large retrospective analysis from the Cleveland Clinic, discussed in AJMC in 2025, found that in actual clinical practice, weight regain after stopping GLP-1s was significantly less dramatic than in the trials. Why? Because in the real world, patients who stop often continue managing their weight through diet changes, exercise, other medications, and ongoing lifestyle strategies.
And that's the whole point of how we approach this. The medication creates a window. During that window, you're not just losing weight, you're rebuilding. You're learning how to eat differently. You're building muscle through your strength program. You're optimizing your hormones. You're correcting nutrient deficiencies. You're changing your metabolic health at a fundamental level.
And if you do that work, if you genuinely modify how you eat, if you build real functional muscle, if you optimize your hormones, you are now in a fundamentally healthier, more metabolically resilient place. That's a different body than the one that started the medication. Your insulin sensitivity is better. Your muscle mass is higher. Your metabolic rate is supported. You're not the same person metabolically as when you started.
So is the medication forever? For some patients, a maintenance dose long-term is the right answer. Obesity is a chronic disease just like high blood pressure or diabetes. We don't tell someone to stop their blood pressure medication just because their numbers normalize.
But for other patients, the ones who use this window to truly transform their health, there may be a path to reducing the dose or transitioning off while maintaining their results. And that path is built on the strength program, the nutrition changes, and the hormonal optimization, not on willpower alone.
The studies that showed massive weight regain were essentially studying what happens when you take away the medication without replacing it with anything else. That's not what we do. We build the foundation so that when or if you step away from the medication, you're standing on solid ground.
My advice? Don't think about this as, how do I get off this medication? Think about it as, how do I use this medication as a tool to build a body and a lifestyle that can sustain my results long term? That's the real goal.
I think the takeaway from today is that these medications are powerful, but they're not magic. They're tools, and like any tool, the results depend on how they're used, who's guiding you, and what else you're doing alongside them.
If you're starting a GLP-1 or thinking about it, here are the questions you should ask your provider. Are you doing individualized dose titration, or are you just following a one-size-fits-all protocol? Are you monitoring my body composition with in-body scans? Are you checking my nutrient levels and supplementing proactively? Are you helping me build a nutrition and strength program to preserve and build lean mass? Are you evaluating and optimizing my hormones? And are you helping me build a foundation so that my results last beyond the medication?
If the answer to those questions is no, you might want to think about where you're getting your care.
Because weight loss without health doesn't last. And health without a comprehensive plan is just luck. Thank you for joining us today on the Rare Wellness Podcast. If you found value in today's episode or learned something new, please subscribe, leave a review, and share this podcast with a friend. Your support helps us continue to provide free content to empower you on your journey to better health. This is Dr. Jamie Lewis reminding you that your body holds incredible potential to heal, thrive, and perform. Sometimes it just needs the right tools to unlock its full potential.
For more information on the topics we covered today, visit rarewellness.com. We'll see you next time.